Before starting our webinar, let me hand over to Dr. Teresa Kazaeva, Director of the WHO Global Tuberculosis Program, for her opening remarks. Thank you, Teresa.
Thank you very much, Marta. Dear colleagues and friends, good morning, good afternoon, good evening. As you all aware, tomorrow the world is celebrating International Women's Day, and it's my great pleasure to have you all for this special WHO webinar with a focus on aligning the gender equity and social protection agenda towards ending TB. As we are all aware, TB is remaining one of the biggest infectious disease killers in the world, and we've seen also devastating impact of the COVID-19 pandemic. And on the progress towards ending TB, we are off track, and there have been significant issues across the globe, mainly in the high TB burden countries, with the access to the essential TB services. And for the first time over the past 20 years, we've seen increase in TB incidents, as well as, unfortunately, increase in TB death. And we should try to do all our best and to provide really comprehensive response and to address all the issues and all the inequalities and the stigma and discrimination, which is unfortunately accompanying TB. The burden of TB, it's also well known that it's higher among men. However, it's also known that women have less access to TB prevention, diagnosis, and treatment services. They're more vulnerable in experiencing frequently issues of quality of care due to TB-associated stigma, and often poor integration of TB services with the reproductive, maternal, and child health, the remaining problem to access to all of these kind of essential services for women. Also, women frequently bear the most severe financial, psychological, and social consequences of TB. That's why TB is also well known and could be called as a family disease. Designing, implementing, and monitoring, evaluating gender transformative TB programs represents a good opportunity to ensure that human rights principles relevant to gender are protected when delivering people-centered care for all genders. A gender transformative TB response is not only necessary to meet this gender equity imperative, but can also accelerate progress towards ending TB. Today, we will be also looking and exploring a role of social protection in this gender transformative agenda, which will add value to the efforts to end TB epidemic. In particular, social protection can contribute to strengthen our response by increasing income of women, reducing stigma, eliminating the social exclusion, and enhancing access to healthcare services. Of course, other important issues and frequent, unfortunately, issues could be also addressed, such as school enrollment and retention for girls and adolescents, among other benefits. In other words, TB response could be used here as a pathfinder, as an entry point to address many gender-specific inequalities. Let me thank in advance the speakers of this panel session, and we value hearing your experiences in working for more gender transformative responses to TB. On behalf of all WHO and its Global Tuberculosis Program, I would like to thank all of you for your dedicated hard work, for your participations and commitment to end TB. With these opening remarks, I wish you all fruitful deliberations during this webinar. Thank you.
Thank you, Teresa, for setting the scene. Let me introduce you briefly this webinar. So as Teresa said, to mark the International Women's Day, WHO has gathered together the voices of women affected or at high risk for TB, researchers, policymakers, to raise awareness on TB among women and start aligning their agendas. The webinar will have 6 panelists giving different insights on the topic of gender, equity, and social protection in the fight against TB. The webinar is also live streamed on YouTube and will be recorded. We would like to receive your questions, and you can see there is a Q&A box in the window of this webinar, so you can find that icon, and please feel free to share your questions. If times allow, then we'll be ready to answer them. If not, we'll follow up after the webinar. I kindly ask all the speakers to please turn on your videos so we can have a quick picture of the panel. Okay, Anna, can you confirm that we have such a picture?
Yes, Marta, all good. Thank you, everyone.
Thank you so much. And now, without further hesitation, let's move to our first speaker, Jamila Ismailova, Civil Society Task Force Representative and Regional Community Engagement and Gender Advisor, USAID Eliminating TB in Central Asia. She's a global health professional with 2 decades of experience in several program areas, including TB prevention and elimination. Currently working as Gender and Social Behavioral Change Advisor in Tajikistan. Jamila will present her experience in Central Asia, working on promoting gender responses approach in TB. And with that, over to you, Jamila. Thank you.
Thank you, dear Marcia. And let me now share my screen. If you could please confirm you can see.
Yes, perfect, Jamila. Yes, we can see that.
Yeah, you can see. Okay. Yeah. Once again, good morning, good day, and good evening, dear webinar participants. And first of all, I would like also to congratulate all the female participants of this webinar with this International Women's Day, and wish you all success, love, and happiness. So with this presentation, I would like to share with you the experience of enhancing the gender responsive approach in Central Asian countries in TB program. So, and I would like to start my presentation by share the story of Shahlo with you. Shahlo is the 32-year-old mother of 2 children from rural Tajikistan. Tajikistan is one of the Central Asian countries. Her husband was a labor migrant who would leave every summer to work to Russia. Shahlo contracted tuberculosis when she was taking care of her mother-in-law, and unfortunately, her mother-in-law passed away. But after the diagnosis, Shahlo's life began to change because after pressure from her husband's relatives, from her sister-in-law, her husband soon abandoned her and left her along with her 2 children. From the quote, from the interviews, quote of Shahlo, you can see in the slides, her quote saying that my diagnosis was made public by her family-in-law, and everyone treated me with disgust. Even though I wore a mask and ate food separately, I was treated as an outcast. Shahlo and her children were forced to move in her family, in her parents. Unfortunately, this story is one of the many stories like this from the Central Asian countries, and I would think not only Central Asian, but the countries that is like traditional, more traditional countries and culture countries. And so unfortunately, often this story and this situation happens among women working for more than 20 years in TB program. I never heard any stories that men were kicked off from the family by having TB, though I don't say that I would like to say it, no way, but this is one of the example of gender inequality in TB. Just some, would like to give some thoughts about TB and gender. I'm sure many of you already know that, but it's good for us to remind ourselves that gender is a social construct that intersects with but differs from biological sex. It refers to the socially constructed norms, roles, behaviors, attributes, and relations that a given society considers appropriate for women and men. This affects responsibility assigned, activities undertaken, access to and control over resources, as well as decision-making opportunities. Gender norms and stereotypes puts women and men at different level of exposure and vulnerability to risk factors for disease and injury. Gender intersects with other social determinants of health and forms of discrimination, influencing exposure to health risk, health-seeking behaviors, and the ability to access health services. Unequal gender power relation and harmful gender norms and stereotypes affects the health and well-being of women and men in a number of different ways. Gender affects health-seeking behavior and shapes how women's and men's health needs are perceived by themselves and by the others. Selection, design, and organization of services often do not consider gender norms, roles, and power relations to respond to the health needs of women and men. And finally, gender impacts the design of health system and their responses to people's health needs. To evaluate the gender and other social barriers that impedes the male and female access to TB services in Central Asian countries, we have conducted study. And here I would like to share with you some of the results from these studies. Regarding the the first step of going and seeking healthcare, it starts from the decision-making in the family. And many of the respondents, and you can see from the slide, almost 80% of female and 49% of male in Tajikistan, 18% of male and 32% of female respectively in Uzbekistan indicated that they need permission from parents, spouse, or in-laws to go to health facility if they have any symptoms or TB symptoms. One of the reasons for treatment interruption by the people affected by TB were indicated the financial difficulties. 30% of female and 22% of male in Tajikistan, 18% of female and 12% of male in Uzbekistan indicated the financial difficulties. And we all know that social support is really needs for people affected by TB to go through this difficult treatment and take their drugs. So the only 49% of female and 51% of male in Tajikistan and 27% of female and 37% of male in Uzbekistan. Once again, this is the people affected by TB indicated that they have received state social support during the treatment. And we also assess the stigma and discrimination as a barrier to that affects the access to TB services. And we have, and the study have revealed that the gender has the stigma has the gender lens on it. And so the statement that in the family it's better to provide treatment to a man first, 53% of male and 48% of female in Tajikistan, and 48% of male and 46% of female in Uzbekistan agreed with the statement. So as I said, this is just part of the study. So there is many other results that we have found to be really important to access to TB services. And by having this result, we have designed and implemented several interventions to improve access to TB services, interventions that we call gender responsive interventions. So the interventions included screening for gender barriers. You know, sometimes people even don't know that the issues that they are facing, these barriers, this is not the norm, this is not tradition and culture, but this is barriers, the gender barriers. So there is a need for screening for these barriers. We just simply added few questions into the TB screening forms, and during the screening, the outreach workers would ask these questions, and if the gender barriers identified, then there is several actions taken to address these barriers, such as psychosocial counseling, advocacy for providing social support, food assistance, legal advice if needed, and escort to health facility, because many times we have found that female don't have, as we already mentioned, power to make the decision and go to health facility. They need somebody to escort them. So we also took several interventions to build capacity of the stakeholders, health providers, and conducted gender sensitization training. We also integrated gender into training and information materials, and supported provision of different gender-sensitive TB interventions, such as addressing gender-based violence, if you remember the story of Shahlo. And also we had interventions for women empowerment to support female people with TB with income generation. So just a few results. As you can see, the screening for gender barriers revealed that almost 35% of people screened have faced gender barriers in Tajikistan, and there is interventions that we're taking, and it's and there, as a result, this is the result of the 1 year of implementation. 298 new TB cases were diagnosed. And in Uzbekistan, as you see, 55% of people who were screened had gender-related barriers. And also there was intervention to address them. By the end, if some of you wonder what happened to Shahlo, I would like just to continue her story. Shahlo was fortunate to receive support from the outreach workers, from the community, social support, all type of support that she needed for her to recover. And this is her 2 children. Also, Shahlo now became a compassion guide for other TB patients in her community, guiding them through the treatment to cure. She is an outreach worker, very active and supporting her community. Thank you so much. This is the end of my presentation. And yeah, I think the question and answer session would be by the end, so I will try to answer any question you might have. Thank you.
Thank you so much, Shamila. This was very interesting. Thank you very much for sharing this experience. Now we move to our second speaker, Dr. Jeremiah Chikovore from the Human Sciences Research Council in South Africa. His areas of research include social aspects of health, particularly of tuberculosis and HIV/AIDS, sexual and reproductive health, as well as masculinity and men's engagement with their health. Today, he will discuss gender as a social determinant of TB. Jeremiah, the floor is yours. Jeremiah, so you are muted.
Thank you, Masha. You can hear me now?
Not really well. If you can increase the volume or move your mic.
Yeah. How is this now?
Is better. Thank you.
Okay, thank you. And good morning and good afternoon and good evening to our listeners. And thank you to WHO for inviting me and giving me this opportunity to join on this very important day. I'll just share some slides and let me know if you see them.
Yes, we can see them. Perfect. Thank you.
So today I will very broadly talk to the overview of TB epidemiology, and we have already started to hear about it. The way men seem to be overrepresented, and then I will move to characterizing gender as a social determinant. We also have heard the same from Jamilia, and the implications for women and TB. And then I will reflect on what possible strategies we could think about, particularly in terms of shifting ground beyond discussions and conversations. Certainly not to imply conversations and debates are not important, but really to think about what can practical issues can move the ground. I'll also touch a little on the pandemic, which really has reconfigured all life as we knew it before, and and possible considerations in relation to a focus on women and tuberculosis. So if you look at this slide, and we have had this by way of numbers, TB appears to affect men more than women, and we have to look at this also within the limits of the absence or scarcity of data that covers gender non-binary persons in analysis. We are seeing some work starting to emerge, but certainly this is also an area that has been missing in conversations. However, a challenge of running with numbers is that they can almost assume a life of their own, and they can be interpreted as denoting that there is heightened vulnerability for one group or one gender. In the case of men, even though we have seen these figures more and more in recent years, this perception is not quite, we haven't seen that perception. And a part of that has to do with the fact that men have not been a focus of attention in most of the previous work. However, as you heard in the introduction, my work has been also primarily with men, and I'm among the voices that have urged redirecting focus to men. Yet, in so doing, I remain with the highest conviction that women have special and they have multidimensional and they have historical but also persisting vulnerabilities, and for that reason they remain a priority. And therefore, it's an honor to have the opportunity to re-underline this position, but from the privileged insights that are drawn also from working with men. So as highlighted earlier, gender is a social construct. It is relational, and it involves relations of men, women, and gender non-binary persons, all of different characteristics, ages, ethnicities, and others. And they relate within their groups, but also across the groups. So as a social construct, gender influences health through the intersections with the various identifiers and variables, but it works in a dynamic way. It is grounded within context, and for that reason, sometimes it is also contradictory. And mapping this influence or the way it works can be time and resource intensive, but it requires ongoing investigation in different contexts and in different and perpetually shifting environment. And these shifts happen for different reasons. A host of factors. It could be climate change and related disasters. They can shift gender relations and experiences with health drastically. It can be conflict, it can be political and economic environments, and it can also be the changing knowledge scape, or even emerging pandemics and historical factors. So, for example, through historical dynamics, policies in some countries in the global south during the colonial era, and I mention this because what happened has left a mark that continues to affect how people relate, how men relate with women, and how women relate with men. So some policies were deliberately crafted to sustain a system of social and economic relations that favored certain groups. And women, for example, were alienated from resources that included land and capital. Families were separated, and this worsened the risk of STIs then, and in later years, we saw that in the way HIV evolved in countries that became vulnerable. But HIV is also linked to tuberculosis. So in teasing out these issues, multidisciplinary studies can and do play a key role, and it is important that they are supported. So just to add more to what I was talking about, so men were affected historically in very special ways, and this shaped their own risk, but also how they relate, as I said, with men and other men and women then and today. So as we look at the numbers, and as the numbers point to men appearing to fare worse in many TB outcomes, the numbers, we should not forget that the numbers for women, firstly, are also large on their own account, but women are affected in qualitatively specific ways, and the multidimensional injustices that they've endured across time and across space means that it is important to place them within the complex melex that shape them. And to do this, we must also capture and interpret their perspectives as actors within their contexts. It also means that we must look at women against men and how they relate with men and with other genders. So this is also crucial. Men's actions also directly and indirectly affect women's TB scenario. We have seen studies that show that men are the biggest source of transmission at the household and community level. And when men are unwell, their care demands burden women, who are often the carers, and the loss of income for men when they delay seeking care and become more ill, can threaten or jeopardize the position or the economic position and social position of women and their families, because unfortunately, and this is an issue of equity and equality at the same time, men continue to receive wages that are higher than women's. Where women face greater risk of HIV, this can also translate to heightened risk of tuberculosis and tuberculosis HIV stigma. A case is to illustrate is that of young women in sub-Saharan Africa who have up to 3 or 4 times the risk for HIV as of their male counterparts, and which heightens their susceptibility to stigma. But also we have seen from very recent studies, including a prevalence survey in South Africa, that a TB prevalence survey in South Africa, that young people are not connected to care. They remain undiagnosed in the community. So these issues tend to be tangled, and what they do is they affect younger women because of their TB rates and of their experience of stigma. Stigma also takes very specific forms for women. It ruptures their social and economic lives, and their role as carers exposes them to infection, and this from the substantial work that was done during the COVID pandemic, we are also informed of the disruptions that happened to care access, the loss of income, and the gender violence that was associated with lockdowns when women were exposed to increased incidents of gender-based violence, and the redirection of resources from tuberculosis in order to meet the needs and demands of the new pandemic. Women also tend to be employed in less secure jobs, and so economic downturn will likely hit women more severely. And in some settings, women of certain demographics work in frontline jobs with limited social protection. So there is need to understand more clearly and fully, and I think this is an area that is critical to open up and tease out more, how to understand how fully the COVID-19 has affected women's vulnerability to tuberculosis. So
Jeremiah, sorry, just to remind you, you have 1 minute left.
Thank you.
Thank you.
Okay, thank you. I will just wind up now. So in terms of some thoughts, gender analysis, including intersectional gender analysis, is really critical, and there is need to address stigma and laws that affect women, and it is also important to frankly evaluate how interventions may worsen vulnerability and to understand the role of other factors in molding the direction of impact. In addition, TB is a disease that responds to social, political, legal, cultural, and economic determinants, and addressing it requires coordinated efforts from multiple angles. It is also important to address the feminization of poverty, and it requires dealing with all the mechanisms that sustain poverty and social exclusion and violence for girls and women. It is also important to ensure that young women have access to sexual and reproductive health services, and also we need to implement multi and interdisciplinary research and evaluation strategies. We also need to look at women as diverse rather than consider them as uniform. I think I will stop there, Marcia. Thank you. Thank you very and much to our listeners. Thank you.
Thank you for walking us through the concept of gender as a social determinant of TB. Let's move to our next speaker, who's Ashna Ashesh, lawyer, public health professional, and MDR TB survivor, SATB from India. Her work focuses on TB and mental health, gender and TB, diversity, equity, and inclusivity in patient support and care. In today's webinar, she's going to talk about the gendered impact of the social determinants of TB. Ashna, thank you for joining us. The floor is yours. Jeremiah, could you please stop sharing your video, your screen, so Ashna can share hers? Thank you.
Is my screen visible?
Yes, we can see your screen.
All right. So just a quick caveat, I pre-recorded this because where I live, it tends to get really noisy and there's a lot of honking around this time. So I'm just going to be playing the recording of my presentation. And then I'm happy to take any questions that anybody may have in the chat. Thank you.
Can't hear, no? Ashna, actually, we can see your video, but we can't hear the sound. We can't hear.
So when I'm screen sharing, you can't hear the audio on my presentation at all. Is that what you're saying?
Yes, if you can go through your presentation live would be better.
Okay,
Thank you.
sure, I will do that.
Thank you so much.
Apologies for the honking in advance. I'm just going to share my presentation then. Is it visible?
Yes, we can see your presentation and hear you very clearly. Thank you.
All right. Thank you so much. Very good afternoon. I'm Ashna Ashish. I'm a lawyer, public health professional, and a DRTB survivor. I'm associated with a collective Survivors Against TB, which is one of India's first TB survivor-led collectives advocating for person-centered TB care and better access to TB care across India. I'm going to be presenting today, as Marcia said, on the gendered impact of TB's social determinants. So just a quick intro before, okay, for some reason technology has decided to really give up on me today. My slide isn't.
I can try to share.
Yeah, could you? I don't know what
Just
it
give
is.
me a second. Yes.
So sorry for the inconvenience.
Let me know when I have to move slides, Ashna. Thank you.
Sure. Thank you so much, Marcia. Right, we can move to the next slide. So just a brief intro before we dive in. As we know, biological factors aren't the only factors that influence our health. Social determinants have a powerful impact on health as well. Social determinants of TB particularly can increase the risk of TB incidence and adversely affect access to TB care. And when you look at the impact of social determinants, as we have seen through the presentation of my esteemed co-panelists, that tends to vary based on factors like gender, sexuality, caste, ethnicity, religion, to name a few. However, the focus of my presentation today is on how that impact varies based on gender. So what I'm going to be doing is presenting findings from our work at SETB, and I'm looking at particular determinants given that time is a factor here. So I'm only looking at housing, poverty and undernutrition, and access to healthcare. And I'm speaking in my capacity as a public health professional, but also as a queer MDR-TB survivor. Could we move on to the next slide, please? Thank you. Before I jump in, just a quick footnote on the definitions. When I say cis women or cis men or cisgendered, what I mean is a person that identifies with their presumed gender, right? And while cis persons could be straight or queer, the reason I've done this categorization here is because when you talk about the LGBTQI++ community or cis women, it's not that they're monoliths at all. Intra-community, inter-community, there are diverse needs and diverse experiences. But some of the challenges that they tend to face tend to overlap. And just for that sort of organizational purpose is why they're clubbed together here. Right. So with housing, for cis women, what often happens is those who live below poverty line are forced to live in poorly ventilated and overcrowded places and clean up after others. Married cis heterosexual women are often abandoned by their husbands if they have TB, given the stigma around TB. They lose access to housing. This adversely impacts not just them, but also their children, because often what happens is a woman is abandoned with children. And the fear of this sort of abandonment and losing familial support and housing often means that cis women forgo diagnosis or take their medication in hiding. When it comes to LGBTQI++ persons, they are often denied access to housing based on their gender and or sexual identity. Now you add something like a TB diagnosis to that mix, and there's another layer of stigma on top of that. And so they're often ghettoized, forced to live in places with poor ventilation and overcrowding. Now, just to be clear, none of this is to say that this does not impact cis men as well, right? But the health research shows that women and non-binary and or trans persons' health in general is more severely affected by poor housing or the lack of access to housing. Next slide, please. So we're going to look at poverty and undernutrition now. Again, when it comes to cis women, in the Indian context at least, they're more likely to not have access to a source of income or financial security, given the very sort of patriarchal gender roles where women are either discouraged or in some cases straight up not allowed to be breadwinners. Even if they do work, women from marginalized socioeconomic strata tend to work in the informal sector for a meager income. And this kind of poverty and undernutrition tend to be linked, particularly not just because they may not have the means, but given their socialization as caregivers, whereas women were taught to prioritize everyone else before we even think of ourselves, they tend to prioritize children and families' nutrition more than their own and often neglect their own. With LGBTQI++ persons, they do tend to lack a stable source of income because there's discrimination in the workplace. Not everyone is welcoming and inclusive and willing to employ them, given their gender or sexual identity and the stigma around it. And sort of this forces them into poverty. But what gets trickier also is the access to welfare schemes, because often, and by way of example, trans persons with TB or HIV, right, if they need to apply to benefit from some policy, a lot of the bureaucratic mess that they have to go through, whether it's getting their chosen name accepted versus the name that was on their birth certificate, or even a sort of a medical note talking about their status living as a person with HIV, all of this tends to make them experience more stigma within that system and is very harrowing. It's a Herculean effort to even get those documents accepted, and it makes it more difficult for them to access basics like nutrition and of course other welfare benefits. Next slide, please. Okay. When it comes to access to healthcare for cis women, so in rural areas in India, access to female doctors is often limited. That's of course changing with having more female doctors come in now, but In areas where there aren't enough female doctors or there aren't any, women may feel inhibited approaching male doctors in remote areas and far-flung areas. Then there's the question of lack of access to health information. They may not own phones, or they may not have the requisite literacy, whether it's digital or health literacy. Because even today, while we have made progress in leaps and bounds, but even still, education for females is less prioritized as compared to their male counterparts. And then, of course, there's the stigma that threatens cis heterosexual women's marital prospects and family life. It kind of holds them back from accessing TB care services. It's gotten to a point where I know of survivors with TB, and myself included, and one of the first questions our extended relatives had is about marriage, not about our prognosis or how we're going to get better. It's about, what will happen about your marriage or what will happen to your existing married life. So priorities. But with LGBTQI plus persons, the tricky part here is that the stigma and discrimination often comes from within the health system itself. And this discourages them from approaching or accessing healthcare. We've interviewed several members of the LGBTQI plus community, including TB affected and persons living with HIV. And the common thread through their experiences was how often they felt dehumanized. There were instances of staff ridiculing them, making fun of their chosen names, making fun of their gender. There are instances of doctors refusing to physically examine them, blaming them for getting TB or contracting HIV, asking invasive questions with no medical relevance. And the fear of sort of going through these indignities is so palpable and so real that there are actually instances where queer people have been forced to choose death over approaching the health system. They've perished because of whatever illness they had, but they couldn't find it in themselves to go back to a system that is supposed to give them care, but instead meted out, in their case, discrimination. This is not to generalize, of course, but this was their particular experience with certain health centers, right? Could we move on to the next slide, please? So what is the way forward? I believe my co-panelist who's going to present after me is going to go into this in more detail, but I'm just here to give a broad overview to sort of bring all of these threads together in my presentation. One would be to prioritize research on the gendered impact of social determinants of TB, because I can speak definitively to the Indian context. While we do have research coming up now, and that's fantastic, we don't have enough to be able to concretely make policy decisions or standards of care across a diverse set of individuals. What we have is very limited data that still needs to be on a larger scale to be representative enough. And when we look at social protection or TB care, these need to be gender equitable and gender responsive in their approach. Another very important thing is that social protection policies have to be co-designed by TB affected persons from diverse genders and sexual orientations, and this applies to TB care policies as well. Again, these protection policies and the care policies need to address not just the varied needs of diverse genders and sexual orientations, but also the varied impact of social determinants for different people. And sensitization and capacity building for social protection providers and healthcare staff to equip them to provide gender equitable and responsive care and protection is, of course, very critical. Next slide, please. So this was actually a question that one of the trans individuals I interviewed had asked me directly. They didn't want to be identified, but they did want this to sort of be vocalized in forums. And the question they'd asked me, as you can see, is how many of us need to die before we realize our lives matter too? And for me, this is a very sobering reminder of why all of us here in this webinar and all of us in TB advocacy and research and policy, why we do what we do, right? Often questions around gender equity or gender responsiveness boil down to the correct pronouns and what is the correct term for this and how inclusive are we being and what is politically correct. And of course, it's important to get the pronouns correct and be inclusive in our terminology, but beyond that, also what's at stake, and this is what this reminds me, is that there are lives at stake here. The work we do here today and in the years to come is going to determine what lives would look like for people from different genders and sexual orientations. And that sort of, keeps us going even when things get difficult. So thank you for your time. With that, I come to the end of my presentation. Thank you very much for having me here.
Thank you very much, Ashna, and thank you for presenting this lens to the topic. Before moving to our next speaker, I would like to invite all the participants to ask questions in the chat or in the Q&A. I see that our panelists are answering those who are already posted. So our next speaker is Dr. Delia Boccia, consultant at WHO. She's a quantitative epidemiologist experienced in the field of social epidemiology of infectious diseases and TB in particular. Her main area of interest is the social and structural determinants of TB and the design and evaluation of social protection interventions able to tackle these factors. As a WHO consultant, she's working on social protection for TB, and she's going to present on gender-sensitive social protection programming in response to TB. Delia, the floor is yours. We can see your slides, but also with your notes, not in presenter's mode. So if you can change that, maybe.
Yes, I'll try again. Sorry for this. I'm afraid that I seem not able to change this. Can you see that? Can you see it better?
Now we can't see any slide.
Okay, just a second.
Yeah, Delia, are you there? Because now we can't even see you and the video. Okay, so while Delia fixes these technical issues, and apologies to all participants for that, we can move to our next presentation. It was actually a joint presentation from two speakers, from Dr. Maureen Sekade, who's a technical advisor at the Uganda Ministry of Health and National Tuberculosis and Leprosy Program. Her current role includes provision of technical leadership for the national and subnational TB child and adolescent response. She has additional experience in infectious diseases, clinical care, capacity building, and among others, she's also member of the WHO Strategic Technical Advisory Group for TB and the WHO Child and Adolescent TB Technical Work Group core team. She's going to present with Dr. Kerry Vinay, team leader, Global TB Program, working on TB and comorbidities, TB in children and adolescents, and vulnerable populations. They are going to focus their presentation for this webinar on social protection and where maternal health and childhood tuberculosis meet. Over to you. Thank you.
Okay, thank you, Marzia. Kindly confirm whether you're able to see the presentation and hear me.
Yes, we can see the presentation and also hear you.
Okay, so Kerry and I will just take us through social protection, where maternal health and child tuberculosis meet, and I'll be sharing a Ugandan context. But before that, I wish to bring us to speed on the context, and here we will draw from the Sustainable Development Goals, particularly goal number 1 and goal number 3, which we think are interrelated. 1.3 focusing on countries or nations implementing nationally appropriate social protection systems and measures for all by 2030. And we're all familiar with SDG 3 that focuses on health, good health and well-being. And we just listed 3 looking at maternal health, under 5 health, and ending the epidemics of AIDS, tuberculosis, malaria, and other diseases. Just to take us through the Ugandan context, in 2019, the country conducted a TB patient cost survey that documented 56% of females with TB suffered catastrophic expenditure. And this proportion was also similar to men. But in the vein of the theme for tomorrow, we thought it would be great to highlight this very large proportion. Additionally, 2/3 of the survey participants reported serious and very serious financial impact at household level. Significant to note is that women incurred higher costs, both medical and non-medical, and these were really direct and indirect costs compared to the men. Overall, less than 5% of the study participants reported receipt of social protection after TB diagnosis. In the context of a child, child health or child psychosocial support, the survey documented that about 12% of participants had their children drop out of school, and that is a very critical for us if we are to end suffering in children. I felt that we needed to get a glimpse of the coping mechanisms for the survey participants. A significant number lost their jobs. People sold assets just to get care. 26% took loans. Nearly half had a food insecurity, and some also had saving mechanisms to cope with the challenges that were related to the TB diagnosis. And this schema really just looked at the interplay between maternal health and child TB, as well as the social economic impact. And Jamilia really took us through a story that highlights this. Coming from the maternal health aspect, if there are issues around maternal health that destabilize maternal health, we'll really see increased expenditure, reduced income, withdrawal of children from schools, food insecurity, separation of parents. And I think from Shahlo's story, we can really testify that this is very, very critical. And this would essentially also affect the health of the children. This can be indirect effects or directly. And similarly, if a child develops TB, and this was also documented in the patient cost survey in Uganda, we see that the children will miss schools. There are issues related to psychosocial distress, and the parents or caregivers will go through several coping mechanisms to ensure that the child receives care, but these also in turn will affect the child's general well-being, which is basically the health. Looking at the policy landscape in Uganda and focusing first on the health sector, we do have a strategic plan at the Ministry of Health, from which we draw the patient-centered national TB and leprosy strategic plan. And we have made some progress towards ensuring social protection. We have a social protection as a key intervention in the strategic plan, but we are also implementing the multi-sector accountability framework for TB. We have developed one for the country, and specifically that highlights the Ministry of Gender, Labor and Social Development action that were agreed upon by both sectors. And what is encircled in red really focuses on social protection. And again, we continue to advocate for universal health coverage. Looking at the policy landscape beyond the health sector, the country is implementing the National Development Plan 3, 2020 to 2024-25, which has a goal of increased household incomes and improved the quality of life for Ugandans. This is also being implemented via a Uganda National Social Protection Policy that has also been costed. There's an investment case. And the reason that I am displaying this is really to highlight the opportunities for us to leverage in terms of social protection. We have examples in the country where patients are provided with enablers. These include food, transport, and also facilitated referrals in some scenarios. The other opportunity is really for us to map out the broader women and child sensitive social protection programs. And these are really hinged under the Ministry of Labor, Gender and Social Development. These are broad nutrition, education, and income generating activities. And we also are really pride in the fact that there has been an assigned focal person for the MAFTB at the Ministry of Gender, Labor and Social Development. And the program continues to engage the sector via or guided by the country-specific multi-sector accountability framework for TB. So what have we learned is that mapping key policy and guiding documents and stakeholders is very key if we are to address the issue of social protection beyond the health sector. And there is need for enhanced advocacy for inclusion of the needs of women and children with or affected by TB. And also the MAF-TB framework really facilitates engagement with other sectors and stakeholders involved in social protection. And last but not least, universal health coverage is a vital component of social protection. I wish to hand over to Kerry, and Kerry, just let me know when I need to move to the next slide. Thank you.
Great. Thank you very much, Maureen, for providing that perspective from Uganda and outlining the situation in Uganda. So I'm just going to conclude this section of the program by bringing us back to the title of Maureen and my presentation, which is Social Protection, where maternal health and childhood tuberculosis meet. And I really wanted to emphasise that expanding social protection for all women will have a number of positive effects, including strengthening women's agency, so their ability to take action or to choose to take action, increasing their income, reducing social exclusion and stigma and potentially other discriminatory and harmful practices, as well as enhancing access to healthcare services, which is relevant to our presentation, including for families and children who are either exposed to TB and maybe contacts, or for those who are diagnosed with TB, and promoting school enrolment and retention for girls and adolescents in particular. Next slide, please, Maureen. And finally, just to conclude, we do have a number of opportunities, I think, to promote social protection. And in our current guidance, of course, we do have an emphasis on the role of social protection for TB. We've released new operational handbook and guidelines on TB in children and adolescents, which emphasize the role of social protection. We're in the process of updating the roadmap on ending TB in children and adolescents, and this will recognise the important role of social protection for women, families, and the impact on their children. There is, of course, ongoing measurement of patient costs, and Maureen has spoken about the Uganda National TB Patient Cost Survey. WHO has just published a document that summarises several TB patient cost surveys carried out between 2015 and 2021. And there needs to be some decisions and discussions at the country level on how to mitigate these costs, including through social protection. And finally, I think there is strong recognition that to end TB, we do need to strengthen multi-sectoral collaboration, as Maureen has spoken about, across not only the health sector, but across social protection and other relevant sectors such as environment, labour, women's and gender, and other sectors to halt the global TB epidemic and save lives. So Maureen and I are going to conclude. We'd just like to acknowledge our colleagues, and Maureen has provided some references for some of the aspects in her presentation. So thank you very much.
Thank you very much, Maureen and Carrie. We can now go back to Delia for her presentation as the last one of this webinar. Thank you, Delia.
Hi, good afternoon, and sorry for the inconvenience before. I seem to be experiencing problems and I still can only show the screen in this way. So I wonder whether it's better for Marzia to go ahead with the sharing, or you can bear with this outline of my slides.
I'm going to share. Let's see if it's working for me.
Okay, I'll stop sharing. Apologies for these technical issues.
Okay, go ahead, Delia. Thank you.
Okay, so again, apologies for this technical inconvenience. As mentioned by Marzia, since September 2022, I've joined the Global Tuberculosis Program as a WHO consultant. And I will speak today in this capacity, and I will use these few minutes to guide you through some notion and definitions of gender-sensitive and gender-transformative social protection, and how we can best design gender-sensitive social protection programs in the response to tuberculosis. Next slide, please. With social protection, let's start with a definition of social protection, because admittedly it can be sometimes a bit of a nebulous definition. There's no single definition, in fact, of social protection. Almost every single institution, policy or implementation, social protection institution will have its own definition. In light of our collaboration with ILO in GTB, we tend to rely on the definition that has been provided by ILO, which you see displayed in this slide. And I have highlighted in blue the keywords of this definition. So first of all, social protection is a human right. It is designed to reduce and prevent poverty and to act throughout the life cycle of people. That means that it aims to tackle critical stages and important aspects of the life of people, from childhood to elderly, going through any form of disability. There are two major categories of social protection: social insurance and social assistance, which include cash transfer. That are probably the most commonly implemented form of social protection in the world. Next slide, please. So social protection is known to have four core functions: the protective, preventing, promotive, and transformative one. For the sake of this presentation, I'm not going to go through each of them, but I'm going to concentrate on the transformative one. Next slide, please. So what we mean by gender sensitive and social protection, transformative social protection, is that social protection is not just an instrument, a tool to tackle the needs of the people living in poverty or the most vulnerable, but it becomes transformative in the moment that it also tackles the root causes of poverty and inequity by tackling issues like discrimination, social justice, and marginalization. By being transformative, social protection aims to achieve a permanent, sustainable reduction or elimination of poverty. And coherently with this definition, gender-sensitive and gender-transformative social protection programs are not just happy to meet the needs of men and women and other non-binary groups in the society, but they also want to challenge and tackle the health inequalities by challenging the norms, the institutions, and the structures on which gender inequalities are based and perpetrated and sustained over time. Next slide, please. As anticipated by previous speakers and Carrie, the impact of gender sensitive and gender transformative social protection is known to happen in at least 4 domains at financial and decision-making level. There are a number of cash transfer programs delivered in India, Brazil, Zambia that have demonstrated that the delivery of social protection and targeting women in social protection programs can increase their voice, their advocacy and agency, and their capacity to have negotiation power in the household. Gender-sensitive social protection programs can also have an impact on the psychosocial well-being of women by reducing anxiety and triggering feelings of happiness, hope, sense of trust in the future, and also satisfaction. And a number of interventions that have been delivered, for example, in Mexico, and female beneficiaries of cash transfer programs were less likely to be victims of domestic abuse. And in India, women that were benefiting from social protection interventions were going through less stress, and they were able to negotiate better in the household, and that also allow them to establish better relationship in the marital relationship. Another important role of gender transformative and gender sensitive social protection is to redefine gender role and attributions, and by not only allowing women to have access to unconventional employment opportunities, but also by allowing for a more balanced and more equitable allocation of domestic duties and childcare responsibilities in the household. In Peru, for example, the beneficiary of Juntos, the national governmental social protection programs, the evaluation of this program has demonstrated that by benefiting from these programs, men were much more involved in the domestic responsibilities in the household. And finally, gender transformative social protection programs can have a role in allowing women to participate better in the social life and the public life in the society. And this is particularly relevant for women that are particularly poor or vulnerable, like single mothers, widows, or divorced women. Next slide, please. But what is the impact of social protection on TB? A growing body of evidence show consistently that social protection interventions, especially in the form of cash transfer, can have a very strong impact on TB treatment outcomes and have a very good impact on TB incidence and the mitigation of costs and the resulting impoverishing effect of TB. We have less or almost no evidence when it comes to the effect of social protection on the uptake of isoniazid preventive therapy, on the uptake and efficacy of BCG vaccination. Next slide, please. However, the issue, another important knowledge gap that we have at the moment is that all these impact findings have never been stratified by gender. So we don't know how this effect of social protection on TB would be different or differential when we look at men and women. However, it is possible to try to adapt and change some of the implementation and operational features of social protection programs to make them more gender responsive and make sure that we tackle better TB among women patients, female patients. In the next two slides, I'm going to show you some recommendations that come largely from the literature available from FAO and UNICEF that have adapted to the case of tuberculosis to show how we can design and implement more gender sensitive social protection programs. Next slide, please. So gender-sensitive or transformative social protection programs typically have the intent to reduce gender inequalities and to empower women. The first thing to do, therefore, when we are determined to design and implement gender-sensitive social protection programs for TB response, is to understand whether there are gender-sensitive issues within TB-affected households, whether there are specific risk or vulnerabilities among women. Countries may want to implement a gender-sensitive TB analysis to understand, therefore, whether, for example, TB is experienced differently by men and women and other non-binary groups in the household. In which way TB affect the livelihood, the well-being, and the quality of life of men, women, and other gender diverse representatives in the household, and the consequences of TB. So, for example, whether TB-related costs are experienced differently. Next slide, please. From an operational and design point of view, there are a number of features that needs to be taken into account in this effort. For example, the beneficiaries. Evidence suggests very clearly that targeting specifically women in a social protection program program has definitely an impact on gender equity. However, in some societies may be not acceptable to address directly women. And in a specific case, in our specific case, it might be unfeasible to address women that might be too sick with tuberculosis to be able to make the most of the benefit. In this case, a compromise would be to identify a female caregiver or to ask the household to identify a beneficiary of the transfer of the social protection intervention, so that by making sure though that it's clear that the transfer is for benefiting the entire household and especially the women and the girls in the household. In terms of size and frequency of transfer, there is no research suggesting a correlation between the size of the transfer and the gender equity outcome of the social protection intervention. However, evidence suggests that the bigger is the size, the more the bigger is the effect of the social protection transfer on the autonomy and the negotiation capacity of women in the household. On the other hand, we need to be conscious that a transfer that is too big may create tension in the household and marital tension. In this case, it's better to reach a compromise by trying to tailor the size of the transfer based on the needs of women in the household, as they were demonstrated in our gender sensitivity TB analysis. It might be appropriate to consider the inclusion of some top-ups to consider special circumstances, like, for example, female affected by tuberculosis that are single mothers or mothers that might need some additional contribution and support in order to avoid that children are either withdrawn from school or even in the most extreme cases sent away, as we demonstrated in a review that was mentioned by Maureen earlier. In terms of delivery, the evidence suggests the opportunity to drop any conditionality. So any behavior that is attached to the delivery of the program. In the delivery process, we need to be aware of the time concern, the time burden, and the limited mobility of women, especially if they're sick. The best case would be to deliver the transfer at the door-to-door level, but if this was not possible, it might be considered to choose a location that is nearby the household and that it takes into account both the safety of the recollection of the transfer, but also that minimize the risk of stigmatization. The point of care for tuberculosis might be a good compromise. Alternative, it might be taken into consideration the opportunity to have, for example, like to link with other services and link the delivery of the transfer with the delivery also in the provision of light touch information about other services that might be very important for women, like maternal health, domestic violence, sexual and reproductive health, and mental health. Next slide, please. So in conclusion, I have, in this few minutes, I've tried to provide you with a list of very basic recommendation to trying to design intervention that might have a special impact on women affected by tuberculosis in a household. And the key important thing is that we first start by recognizing what are the needs at gender level, what are the issues, the risk and vulnerabilities within the household. And then to adapt the intervention based on this assessment, and particularly make sure that we target women as much as possible, that the size and frequency of the intervention is proportionate to the needs of TB-affected women, and also that the delivery strategy takes into account a number of considerations that are particularly sensitive for women. It is particularly important, especially in the context of MAF, also to be able to link with other services to make sure that women receive a comprehensive package of support that is not just about TB, but also other forms of social protection and other forms of health services. And finally, of course, it is important to be able to judge the effectiveness of this gender-sensitive approach to social protection by implementing a monitoring and evaluation framework able to understand the gender impact of this. I'd like to thank you for your attention, and again, apologies for the technical issues. I hope that this last presentation will trigger some discussion about future work in gender responsive social protection interventions for tuberculosis. Thank you very much.
Thank you, Delia. With that, all our speakers contributed to the panel. We are running a little bit out of time. Actually, we are over time. So let me thank all the speakers and the participants. Wish you all a happy Women's Day tomorrow. And maybe I hand over to Teresa for some final remarks. Thank you.
And thank you very much, Marta. And I would like also to thank all the participants of this meeting, all the panelists. For it was really a very rich discussion, and I think that indeed we are setting the scene. It's important step, but please let us know if you think that we should continue having this kind of webinars, and not necessarily only once a year, but more frequently and for sure. And as you could see, for us in GTB, it's a priority. We are really focused on the gender-sensitive specific issues, and we'll do our best to address them better, reflect in all our core technical products, and provide all the requested guidance and support to the countries and partners, including to the civil society groups. And I would like to echo also one of the participants of this meeting, that indeed all lives matter, irrespective of gender, age, of nationality or country. And we should continue following this approach and try to share actively information about TB, so that it's completely, it could be completely preventable and curable. And this is one of the sources of stigmatization. And we should contribute actively to share the latest news and the information about the latest opportunities. Delia mentioned about some specific interventions, but we should ensure access not only to the diagnosis, treatment, and TB preventive treatment, but to the best available according to our latest guidelines, to the shorter, fully oral, much more effective and safer treatment options and TB preventive treatment options. So with this, we are about to conclude, but with your permission, I would like to thank also Tim, who is very passionate and driving forward this agenda in GTB. Marce, Kerry, Natasha, Baras, all contributors, Delia also working with us. And we have here in the room two very quiet males, Dr. Farai Mafunga and Dr. Ernesto Jaramillo, who actually initiated this webinar and inspired these discussions. So with this joint approach, I think that we will succeed and address all the gender-specific and non-specific issues. Wish you all the best and a happy International Women's Day.